Welcome to Early Intervention Matters, the podcast that helps parents, teachers, and health professionals understand the diagnosis, treatment, care, and support of children with autism, ADHD, Tourette's, and other neurodevelopmental challenges. Your host, Dr. Inyang Takon, is a consultant neurodevelopment pediatrician, and she will provide insight through interviews, answering questions, and breaking down complicated topics. By sharing stories from parents and professionals in the field, we hope to make sense of what can be an overwhelming topic. Early intervention is crucial with children with developmental difficulties. Yes, early intervention matters. And now, here's your host, Dr. Inyang Takon.
Hello, everyone. Welcome to another episode of Early Intervention Matters. And thank you for tuning in to another interesting episode. I hope you've all had a good week. We're very fortunate today to have a very expert guest who has done a lot of work in the field that we'll be talking about today. We've got Gilly all the way from Atlanta, and she is a licensed psychologist. I'm going to let Gilly introduce herself a bit more later. She's done great work, which we're going to find out and hear more about as we go through the episode. As you know, Early Intervention Matters is a podcast that showcases different topics on neurodevelopmental disorders. It's geared towards parents, young people, professionals, and members of the public to learn more about neurodevelopmental disorders, understand conditions and differences, and have more awareness into how to support young people. So we're very lucky to have Gilly today. We are going to be talking about a very interesting topic titled Navigating Emotional Symptoms in ADHD. Now, this is really interesting because I, for one, in my practice over several years, I'm increasingly seeing lots more young people with emotional symptoms as a presenting as more of the more prominent features that comes in when they present with certain aspects of neurodiversity. And it's also quite interesting that sometimes these young people don't have the classic symptoms about ADHD where they might go without a diagnosis. So we're very fortunate to hear from Gilly today. You're welcome, Gilly. Thank you for joining us.
Thank you so much for having me on your show, and Yang, I'm really happy to be here.
Thank you. So I think I'll let you introduce yourself to just give us a summary of your work and what you do.
Sure. So my name is Dr. Gilly Kahn, and I'm a clinical psychologist, a mom, and a writer. And I work in private practice and a group practice, and I specialize in work with teenagers, but I see people across the lifespan, different age groups. And I also specialize in neurodiversity and in emotional dysregulation. And in addition to practicing, I also write. And so right now I'm blogging for Psychology Today, and I just published my first book, which is about emotional dysregulation in women with ADHD. And I was diagnosed with ADHD in adulthood, and I'm among a growing group of women who are getting late diagnosed. And so that's what inspired me to write about that topic, my diagnosis, but also I saw a need for more of this like accessible and readable educational material. As a psychologist who recommends books to her clients, I always found myself kind of getting stuck and feeling like a lot of the books that are available either don't have enough of a focus on women, they don't really cover emotional dysregulation enough in relation to ADHD, and they sound very academic and can seem like dense and difficult even for me to understand or to get through. And so I just wanted something that could be really digestible, easy to read, but still like practical.
Thank you so much. Thank you, Gilly. That's very interesting. And you are absolutely right. You know, talking through emotional symptoms, and it can be, when you find some of the materials, it can be quite difficult to understand. Do you want to define for our audience what you mean by emotional dysregulation or the emotional symptoms. What do we mean when we're talking about that in relation to neurodiversity? How would you define it?
Yeah, so I'm going to connect it to something that you probably have heard of before, which is executive functioning. And we know that people with ADHD struggle with planning and organization, with motivation, and emotional dysregulation is part of that too. Because executive functioning involves, like I said before, planning, but also regulating your behavior in response to a triggering event. So the stereotypical or common misconception of ADHD is like a little boy who can't sit still, who maybe is somewhat oppositional or defiant and is disruptive, which is very noticeable by teachers. And then those kinds of cases are much more readily referred for services because no one likes a disruptive or a loud kid. In girls, we already know that ADHD presents differently, but the problem, in addition to the criteria being written and developed on mostly little boys, is also that it doesn't include emotions. Even down to, like, if you look at the Diagnostic and Statistical Manual, the DSM, which is the main manual in many countries that is being used to diagnose mental disorders. If you look at most of the diagnoses in there, if not all of them actually, toward the bottom, it says that the symptoms need to cause clinically significant distress or interfere in major areas of functioning. But then when you look at ADHD, distress is not even mentioned. I mean, even down to that. So when I'm talking about emotions, it's like if you read the depression criteria or the anxiety criteria, there's clear descriptions of thoughts and mood, but in ADHD, it's just not present. And it doesn't mean that it's not a part of ADHD because in the DSM-5 TR, which is the most recent version that came out just a couple of years ago, that one has like a little, not a footnote, but it kind of feels like a footnote because it's a tiny little paragraph where they say that people with ADHD can also struggle with regulating their emotions. So what does that mean? Emotions are, right? Emotions have different levels of intensity. And then there are emotions that feel good and there are emotions that feel not so good, right? Like anger, anxiety, depression, we think of as like negative emotions. And then there's more positive emotions. I'm going like this because like, what is a negative emotion? What is a positive emotion? But they're uncomfortable, right? The negative one. And the ones that feel good might be more like excitement, right? Pride, happiness, contentment, etc. And so we have different kinds of emotions, and then you can experience different intensity of emotions. Some people are more sensitive than others. Some people feel emotions more strongly than others. And then there are people who really struggle with moving on once they feel an emotion. Whereas for one person, if they feel sad, they can kind of move on after a few minutes. Once they realize, I need to, let's say you're in class and you look at your grade and you got a D, right? So for someone who's neurotypical, they might see the D and, different, it depends on the age group too. Let's say you're older, like a 17-year-old, and you see the D, you might think to yourself, wow, that hurts. But then distract yourself and think, I can't cry in front of all of these students. And so you kind of have that mental shift where you can change gears and think about something else or focus on something else and delay the response. So that way it comes out in a more socially appropriate situation or in a more socially appropriate way, or it has even kind of lessened in intensity because more time has passed. Whereas for people with ADHD, and this is what the research shows, and this has been part of the condition since very, very early on, and I'm talking probably since the late 70s, it's more of like a gut, like a reflexive intensity. So they feel emotions very intensely, and then it might come out right away because it's harder for them to shift and change gears or to distract themselves, it's harder for people with ADHD to think about consequences. So let's say, someone with ADHD gets a D and they think it's unfair, they might spring up out of their chair and go to the teacher and complain instead of thinking about the con of doing that and delaying that response. So there's the intensity of the emotion, there's the ability to shift gears and distract yourself. There's the ability to think about the consequences, of responding in this way. And then there's like the down regulation where it's harder to come down to baseline in a shorter period of time. And all of that is executive functioning.
That's quite interesting because most times when people are thinking about executive functioning, most people are thinking about the planning and organizing part of it. But people don't tend to think a lot about the emotional symptoms. And it does cause quite a lot of distress. In my clinical practice, one of the things that a lot of parents are worried about is the child's reaction. The reactions when little incidents happen. For parents say it as a little trigger and the child has such a big reaction. And like you've described, it's difficult to shift them and it can go on for a long time. And they find that the calm down is different. It takes longer. As you're talking, I was just thinking, how would you then differentiate this from, the emotional symptoms that can occur in young children and teens with autism? Is there a difference in the way they present?
It's a good question. I think there's a lot of overlap between autism and ADHD, and they tend to be, diagnosed together pretty frequently. Also, I think because the ADHD criteria, they're just like so specific to little boys right now. We're
Yeah.
missing a lot of information that I think would
Mm.
make it a lot more similar to autism. But then there's also the main difference is the social component. Like, in autism, it's more of a knowledge than a
Mm.
performance deficit or issue. So people who are autistic can be extremely intelligent, extremely bright. They have a very unique way of thinking, but the main kind of challenge there, aside from the sensory issues and the rigidity, I mean, there are all these other symptoms, but really the main thing that differentiates, I think, ADHD from autism is the social skills and the social awareness.
Mm.
And it's more of a knowledge issue. Like people who are autistic just don't really understand it. It doesn't come to them as naturally. But
Mm.
then when you teach it to them and they practice, and they can perform pretty well. It doesn't mean it's
Mm.
hard for them. Like they're
Mm.
basically acting, right? And there's also a motivation component. Like some
Mm.
autistic people just don't have much motivation to socialize.
Mm.
Whereas people with ADHD, it's more of a performance deficit. So they also have issues in relationships, but it's not a knowledge issue. For example, like I remember when I was younger and I was doing like research for my dissertation. And there's like some studies where kids are given vignettes and they're basically like hypotheticals, stories. And they're asked, like, what should you do in this situation? Or how would you respond? Right. And kids with ADHD typically give the right answer. Like, well, I would do this or I should do this. They know what the right way to behave is. But then when they're placed in the situation and they get angry or frustrated, then they can't behave in the way that they either predict they'll behave or
Yeah.
think they should behave because of the emotional dysregulation. So, and they have the motivation too. Like they want to interact with other people. It
Mm.
just, you know, falls flat on its face.
Mm.
Sometimes, if things don't go the way they want it to, and, people with ADHD, especially when they're like, I guess, more on the impulsive or hyperactive side, like they could be talkative or, like talk over other people. The interactions might be a little bit more one way, like they are in autism, and people don't like that. And so, in either case, there are relationship issues,
Mm.
but for a different reason.
Thank you so much. Thank you. What do you think has been, so just looking at the emotional symptoms and the late diagnosis. What do you think has been the reason why? I know you touched on some of it, but what's been the reason why people have not thought through um, when young people come in with those emotional symptoms to actually explore? Do you find that a lot of them have never had a proper assessment for neurodiversity when they presented with the emotional symptoms? Is that what you find?
Yeah, I mean, I think in most cases, actually, what I see, especially in teens, is they'll come in with an ADHD diagnosis, actually. So, I mean, I do, and I write about this in my book too, and I can talk about Anna, who's like a case I talk about in chapter 1. But there are cases also of girls where they're diagnosed with anxiety or depression first, and the ADHD was overlooked. But in terms of like actually what do I see more often, like in my practice, it's actually teens who come in with ADHD because the parents know that I specialize in neurodiversity. So they bring in their kid who's neurodivergent. But then most of the time, what I see actually is that kid is autistic, like with maybe ADHD too or not. Like autism explains the ADHD, but that is most often actually what I see. And I'm surprised when it happens because like they made it to 12 and they got evaluations and someone went as far as to diagnose them with a neurodevelopmental disorder, ADHD, but then they didn't even consider autism. And that's absurd to me. But like that is, typically what I see. And then it's not even like mentioned in the report. Like it doesn't even say like future assessments should also rule out or consider autism spectrum disorder. And my feeling is that just not enough providers are trained autism testing, and they're also not, I think, well exposed to the nuances, especially in girls. So they see that there are these executive functioning difficulties and they just slap on like an ADHD diagnosis. That doesn't mean that they clearly have functioning difficulties, but a lot of times the autism actually explains their challenges a lot better.
So, and with the teens, could you talk us through some, like a typical teen with the emotional symptoms that you see? Now we're talking about the teenage population. What usually happens? How do they present? What are the key features that you tend to see?
Yeah, so I'll talk about Anna. I think she's just like the perfect example, which is why I used her in my book and for, the people who are pretty precise, like I got consent from them. But then
Yeah.
other cases are, I had to what's it called? Like maintain confidentiality.
Yeah.
But for Anna, so she's kind of like a classic case of a teenage girl with undiagnosed ADHD. So when she came into like for the intake session, she came with her mom, and like the main concern was having a history of emotional dysregulation. Like that's what they came in with. And then she had already completed testing with a psychologist. I think it was 2 years before she saw me. And her mom brought her in asking for an ADHD assessment. And she said, I think my daughter has ADHD. And so after the testing, the psychologist said, I think her symptoms can be better explained by generalized anxiety disorder and specific learning disorder in mathematics because her math scores they weren't significantly below average, but they were below average. And she has a history of like struggling with math, and her other scores were much higher. And so she went to therapy and she saw different therapists for about a year. And then they came to see me and they said, we're still kind of struggling with the emotional dysregulation. And then also they named all of these classic ADHD symptoms in addition to the emotional dysregulation. So for example, her room was a mess. She like her bathroom was a mess. I don't want to get detailed, but it was gross the way her mom described it. She just like had these big emotional moments. I mean, now she's older, so it's like her brain is more better developed. So she's not exactly doing the things that she was doing when she was younger. Like when she was in elementary school, she flipped a chair in her classroom because she was angry and like disagreed with the teacher.
Mm.
And she had like a few incidents, like that. And it wasn't only at school, it was at home. And Yeah, but otherwise, she was like she was a nice and intelligent girl, very talented, and she had friends, but, like, in situations with, like, new people, she tended to struggle.
Mm.
So, yeah, so basically, she came in for the intake, and when, during an intake appointment, like, a psychologist has to interview the family. So I had to ask about it. While they were there, I said, "Can you tell me about, like, the emotional stuff that was happening, like, when you were younger and you're in the classroom?" And she just got up and she said, like, something like, "Mom, you can do this by yourself." Like, she was so angry and she, like, burst out of my office and went to the waiting room. And it was just very startling for me because I didn't understand, like, what did I say? And so by the end of the session, I just had the feeling that she just wouldn't come back. But then she did come back. She came back to, the following week, and I just sat with her. And after we had just like a little bit of like quiet playing time, I was like, "So, what happened last week when you left my office?" And she said to me, "I feel so ashamed when I think about the things I did when I was a kid. I couldn't help it.
Wow.
Be embarrassing." And she was crying there while I was playing with her, and she just carried this with her, and it was not anxiety. Like, I mean, she
Wow.
worried. Yes, of course, she worried about what others thought about her, but it was more this shame and this rumination, and she just wanted other people to like her. And so basically, I referred her for retesting to a different, like, provider. And, we specifically asked for ADHD testing. And then that evaluation where she did do the actual, like, testing, like a continuous performance test, and they gave it more attention, like, it came back and the psychologist agreed that she did have ADHD. And, what I see a lot in my practice and from talking with women who were late diagnosed is that, like, getting the diagnosis and having some clarity and understanding about what was happening is half the battle.
Mm.
It is healing in itself. And I really felt that with Anna because initially, so when she got her evaluation results. She's very direct and very smart, like I said. So she asked me, "Can I see the evaluation?" So first I got consent from her mom because I didn't want to overstep. And she said, "Sure." So I sat with her. We looked through her evaluation together. And her mom had mentioned, well, her ADHD, like the psychologist said that her ADHD is mild, like just like her math disorder, it's mild. In that moment, she didn't like that, so she just burst out of the room and was like, "I'm only gonna talk to you if my mom's not in there." So her mom agreed, she said, "It's fine." So she left, and then she came back and she said to me, like, "It really, really hurts when my mom says that my challenges are mild because they don't feel
Yeah.
to me. And when people say they're mild, it makes me feel like I must just be stupid. Because if this is mild, then, like, what is I don't know, like, what does it take for it really felt like it was really hard for her. And and so then basically, I said to her, because I hadn't told her before, I was just like, "Well, if you're stupid, so am I, because I have ADHD too." And by the way, I also think I have specific learning disorder in mathematics that was just never diagnosed. And, and in that moment, she was emotional, but I saw that she was really doing a lot better after she was getting the medication that she needed, and we started working on the issues with emotional dysregulation. But again, I think just like having the knowledge and the understanding and the self-compassion, that's the biggest piece.
Absolutely. And I completely agree with you. I've also noticed is when young people have gone through years and years, being labeled, giving the wrong labels, being told they're, angry, they're being isolated because of their responses, even friendships at school. They're carrying that burden for a long time. And when people minimize and say, "Oh, that's just mild," or "that's just this,"
Yeah.
it's just interesting to see your dialogue on a one-to-one with Anna and how she expressed that. And I think that that's something that is missing many times from assessments is, sometimes people do these assessments, but the index person involved has not been able to really express in detail how they're impaired by those symptoms. So, I think there's quite a lot of learning that you have showcased in what you've talked about. And one of the challenges that I find when assessing young people, and I think you've touched on it, in that the tools that are out there, they're made for young boys, little boys, and they don't really pick up the symptoms very well. The DSM, doesn't pick up the symptoms very well in girls. And this is usually one of the challenging bits. So when you send those questionnaires to schools, and the schools complete that and they come back with, the child is not scoring at all, or the young person not scoring. And then you're trying to, so the school is again looking at that lovely girl sitting in the corner, not really talking or not really understanding them, and not giving them not scoring them appropriately on the questionnaire for the clinician who is assessing. Do you find this within your practice, and how do you overcome it?
Yes, I write about that a lot in my book. It really bothers me a lot. I think, I can get into like all of the details about the criteria that I think are shortcomings in diagnosing females. I think that is a big one, requiring, because right now, in addition to, the actual content not really being specific to females, in order to get diagnosed, the symptoms need to be significant and present in more than one setting. And so the way that clinicians who provide diagnoses and give these assessments, the way they interpret that typically in childhood is home and school or home and camp. Typically it's school. Camp is rare. And because usually they're doing it during the school year, the testing. Or, so basically if the kid is old enough, the kid will get a questionnaire. And then the parent, of course, both parents preferably. And then they'll give the questionnaire maybe to one teacher. If it's two, then we're lucky. And the problem with that is that most teachers have classes of 20 plus
Yeah.
students.
Yeah.
If girls are harder to detect to begin with, let alone the criteria not being tailored to girls, let alone teachers not being like instructed to the same or informed to the same degree as mental health providers. So yet we're putting so much emphasis on a teacher's report when she could just be totally wrong. The other thing is that teachers are much more likely to refer boys than girls. Yet for girls' assessments, will rule out ADHD if the parent reports that they present with these symptoms. Even if the kid is kind of borderline, maybe because their insight is not great, like the parent sees it, but then once the evaluator sees, well, the teacher doesn't see it, they'll say they're having no problems at school. So, no, not ADHD. You just have anxiety. That's how they say it. Well, you just have anxiety. Because, first of all, why is it just anxiety? Anxiety is, you know, like an anxiety disorder is an anxiety disorder. It is not just anxiety, it is debilitating. But also, it might be anxiety on top of ADHD. It more likely, especially if it's a girl, like the teacher just isn't seeing it. Yet we're placing so much emphasis on
Yeah.
having this, second opinion. And so I think that's a problem. I think there should be more of an emphasis on parents' report, because when kids are home, it's like they take the mask off. In my book, I say it's like kids come home and unleash their dragons. Because at school, it's more structured. They're more worried about being rejected or criticized. Teachers, especially girls, because when you look at brain differences, girls, in terms of brain development, are just better able to hold it together. And that's why teachers love having girls in their classes, because they're generally better behaved than boys. And so they're more likely to fly under the radar and to not be detected or to be considered like mild.
Yeah, absolutely. It just reminds me of one of the young people I assessed a couple of years ago, and this young lady had been really struggling a lot and a lot of emotional symptoms, a lot of emotional symptoms. And when she completed the questionnaire, the self-report, she did flag up inattention on hers. The school where, when they did the tick box, it was kind of borderline and not too strong. But when I asked them to fill a questionnaire to just write things in, I could read in between the lines, and I said, you know, they're obviously describing her with difficulties with ADHD, but because she's not presenting in the typical way, they haven't been able to reflect that on the questionnaire scores. And they decided to go on this journey of reassessing and all that, which eventually they did. And she ended up still having the diagnosis. But it was the trauma that the family had to go through,
Yes.
for the years that they had to go through, because the clinicians were looking at the emotional symptoms and just saying, this is just all due to anxiety. This is just all due to anxiety, not ADHD, not ADHD. Despite the fact that she had had an assessment, I had taken a direct history from her. I had looked at what school had been writing in between. So it can be a very difficult road for young people going through this.
Yeah. With autism, I heard someone comparing autism to like the parable of the elephant. And so, with that story, basically, there's a bunch of blind villagers, and an elephant comes into their town, and they've never seen or experienced an elephant before. And so, they're all trying to understand what an elephant is. So, they decide they're all going to gather around and like feel like different parts of the elephant, describe what they feel, and that way they can sort of maybe get like a coherent picture. And so one of them is touching the tusk, and they're like, it feels like this. And then another one touches like a leg, and they're like, it feels smooth. And with autism, it's like a lot of times when I see like kids who are not diagnosed with autism when they should be, there'll be like a slew of diagnoses, like something involving, sensory sensitivity, sensory integration disorder, maybe given by an occupational therapist, or sensory processing. And then we'll see something like social pragmatic disorder. And then maybe like an ODD, oppositional disorder.
The ODD, the great ODD.
Right. Just like an anxiety, like an other specified anxiety disorder, just like this list, or like an ARFID or avoidant restrictive food intake
Yeah.
disorder. Then with picky eating, it's like all of the symptoms without the autism diagnosis,
Yes, they're giving labels to all the
like the
symptoms.
leg and the tusk, and it's all of the pieces instead of just identifying the umbrella and giving it one name. And so you end up with like overdiagnosis and confusion. And that is what, is happening right now with ADHD, because emotional dysregulation is not included as a core feature of the disorder. People are putting like anxiety, depression, and maybe like a sensory integration disorder, like again, relationship problems like oppositional defiant disorder, whereas that should all just fall under ADHD. And they're misunderstanding, and they think it's something separate, but it's not. And then we
It's
end
not.
up over or misdiagnosing.
Yes, and the trauma of having to keep going for assessments and keep being given different labels each time without understanding the big picture of the condition. I think that's one of the most traumatic things that, young people have, because they keep going for these assessments. This person says this, and then they keep going, and, it's really worrying. Great. So we've talked about the symptoms and all. How do you manage? How do you assess? So when you do an assessment, you are exploring the emotional symptoms in detail to help you understand the presentation. Are there specific tools that you're using with exploring the emotional symptoms?
So I'm not doing psychological testing right now. I'm just doing therapy.
Okay.
I haven't done actually testing in a while. It's been years. Maybe 3 years, 4 years. It's been like 4
Okay.
years since I've done testing. Yeah, so in terms of like the emotional dysregulation for me, it's more treatment. And then I work with like I'll refer to psychologists who I trust. Um and then I end up like consulting with them. But in terms of like the therapy, like I'll do the therapy and then I tell the parents like here's who I think will understand your child. And I give them a few different options. And then I'll usually like consult with that person whenever they're working on like data collection and their evaluation and just tell them what I've seen so far in therapy.
Mm.
But yeah, in terms of instruments, it's just, whatever is available. And then for therapy, if let's say I see an adult who I think maybe flew under the radar, should have an ADHD diagnosis, I'll usually give them like a screener. It's called the ASR.
Oh, yeah.
And that just kind of gives like an idea as to whether, going to a psychiatrist and, you know, getting like a brief, evaluation by a psychiatrist. And I feel like if it's something I think and they scored high on a questionnaire and then also a psychiatrist saw them and thinks the same thing and they're an adult and they don't need accommodations, I don't necessarily recommend that they go through
Yeah.
the entire testing process. The other thing is that there are some benefits to doing it that way. Testing is very expensive. It takes a long time to get in. The thing is that if you have a high IQ or if you're really interested in the assessment, you might still not come out significant on the tests, neuropsychological tests for ADHD. And there's research that shows that too. And so, adults could perform well on executive functioning measures. They have
Yes.
because it's like in a lab environment and it doesn't really cover like the real world.
The real life, yes. And when you say therapy, what does the therapy involve?
So it depends who I'm working with. I mostly work with teens, so a lot of what I do um a lot of it actually does have to do with like organizational skills and I think that decreases the anxiety to a large part because if you have a salad in your brain and, things aren't really organized or planned out, or you don't have any of those skills, because no one has explicitly taught you how to create a list of tasks and then schedule them in advance and break them up. And then there's also just like motivational strategies like the Pomodoro method, which basically, helps you if you have a short attention span, you work for 25 minutes and then you take a 5-minute break and then you do another 25 minutes and you repeat that 4 times until you take a longer break. And using like things like visual timers, people with ADHD, there's a lot of like kind of like co-occurring challenges like sleep. So we'll talk about their, sleep. I'm trying to get to sleep at a regular time. And then there's like sensory things that might help them, like a sleep mask. So that's more the organizational skills. And then in terms of emotional dysregulation and social skills, again, it's not a knowledge deficit, it's a performance deficit. So we develop like specific plans for them to calm down like because that is really what's interfering in their relationships and in their social interactions is maybe their immediate or their gut emotional responses. So we identify like steps they can take, specific to them. Like let's say they're at school or they tend to get triggered like on the soccer field or something. It's like what can you do in that moment so you can remove yourself from the trigger? Because if it's in front of your face, you're more likely to lash out or to do something that's bad for you, like long term. So separating yourself, like down regulating. So how can you relax in the moment and bring yourself back to baseline, making like relaxation skills and, typical kind of like cognitive strategies. So once their emotions have gone down, they can think more logically. And so, what can you do with this problem? Problem solving skills, rethinking the situation, and then what can you do to go back and resolve the issue?
Fantastic. Wow. There's a lot of and this is really good because when we see undiagnosed children or young people with ADHD, it's one thing to diagnose and treat, but then you have all these other things that you have to teach them how to overcome it. So the organizational skills and all these things that you're talking about, they're so key in helping that young person function well. So it's amazing, and just listening to that, I'm very sure a lot of our audience will have learned a lot from even the bits that you have spoken about. So that brings us to your book, which we're excited about. Do you want to tell us a bit about your book and tell us what people can get from it by, buying and reading it?
Sure. Yeah. So I actually just got the hard copy in the mail. So I brought it.
Whoa, lovely. Congratulations.
Thank you.
Wow, it looks really good.
I know. My husband pulled it out of the box and he was like, "Oh my God, there's a typo." And I almost lost it.
Wow, it's
I was
such a
like,
great
"No,
thing.
there isn't one."
It's a great feeling when you've been doing all this work and you just see it come out live, isn't it? It's an amazing feeling. Yeah.
Yeah. So the title is Allow Me to Interrupt. A psychologist reveals the emotional truth behind women's ADHD. And I cover a lot of different topics relevant to emotions and ADHD in women. I focus a lot on rejection, sensitivity, dysphoria. And actually, William Dodson, who's the psychiatrist who
Yeah.
popularized RSD, blurbed my book. So he's on the back.
Wow.
Yeah,
Amazing.
that was really cool. So here but I talk a lot about RSD, and I also include similar. This was like a little snapshot of, more thorough description of what I do in therapy and what I recommend to cope with those and similar challenges. And then each chapter focuses on something different. So I've got like a chapter that focuses on passion, setting goals, one on RSD. I have a couple on addiction. The first one's on reinforce, and then that leads into the addiction chapter, and I include things in there that you wouldn't even consider to be addictions, but when you think about them differently and when you think about how often they co-occur with ADHD, you realize, like, for example, body focused repetitive behaviors like trichotillomania and skin picking disorders, those could totally be considered addictions because they
Yeah.
release endorphins and people find it hard to stop. It's addicting. So I cover PFRBs in that chapter too. There's a chapter on trauma. And oh my God, and if you get through chapter 4, which a lot of people said they enjoyed that chapter, it's the most dense chapter in the book, but that's the biology one. So I wanted to make sure that obviously, if it's a book about women, I had to talk a lot about hormones. I talk about brain differences between females and males. And then I break it down into the different neurotransmitters. But it's interesting. Like I lure you in, and the language is simple. That was the point of the book to make the language simple, make it flow. There's a lot of stories. But yeah, that's the book.
Great. I'm going to get my copy straight away. How soon can people get it?
Yeah, it's being sold internationally. The distributor is Simon and Schuster. And so you can find it if you just Google it. Google the title. We'll share a picture, and then I'll share also a link to.
Yeah. So if you can,
Yeah.
it would be really helpful if you can share that because I think our guests would benefit from that as well. Because I'm already excited with all the things that you've talked about in the book. I'm going to get my copy. Good. Thank you so much, Gilly. It's been amazing. And just before we round up, I just wanted to say, we've been talking a lot today. It's we could go on forever because of the topic I really enjoy, and it's a topic that I think that just listening to you breaking things down makes a lot of sense in terms of, and I feel that more clinicians need to be aware of this because we're seeing more and more young people with, emotional symptoms. Many of them are still not diagnosed because the usual assessment tools and the reliance on the school scoring
Yeah.
negates giving them a diagnosis. And many times you would see a young person where it's been very explicit from their own inside, and then the parents or the schools then report that the young person is doing fine. And I think you've given out really good reasons where, the differences between girls cope better. They want to maintain that, social facade in the school. They're holding everything together. So they won't show those behaviors many times. And the minute they come out, then they take the mask off and then, like you say, unleash the dragon. And then, that's when parents are completely overwhelmed with the symptoms and not know how to function. So I think there is a lot that clinicians need to be aware of the emotional symptoms. There needs to be a lot of understanding. And I think one of the things he brought out today was the fact that emotional symptoms form part of that executive function triad, complex, and that people not only thinking about the planning and the, organizing part, but also thinking about how those emotional symptoms can present and the differences in how they present. And actually, when you're trying to look at emotional symptoms in people with ADHD and ASD, they commonly go together. So when you're exploring for one, it's good to think about the other and just think about the differences with the presentation. But one of the things that you stressed is with ADHD is a performance condition, and that's where you see the symptoms being displayed and all that. As much as you can tell them, they know what to do, but when it comes to the performance, they struggle and they can't hold it in, they can't stop themselves. So it's, I think one key thing is for us to be very aware when we're, navigating, and I like the title of this is just navigating emotional symptoms in people with ADHD, is just being aware that the person sitting in front of you could just have ADHD. And you've talked about the management, the key things, and I can't stress this enough. I think this is really important because it's not just, I think when people think about ADHD, some people think, okay, we'll just take medication and that's it. But
That is
there's
really, yes, immediately, yes.
yeah, people think ADHD, I get the medication and that's it. But no, it's not just it because there's a whole lot of things out there
It's just
that comes with condition. Yeah. No, you were going to say something, Jerry.
the medication is a starting point, but it's not
Is
going to
it?
teach you skills.
Yes, exactly. Pills don't give skills. Yes. So, yes, it's just a starting point, and there's a lot that is needed. So, and which you've touched on a lot, and you've also written a very lovely book for us to go in and explore. And I think that, I would recommend that to people because like you said, a lot of the materials out there, and some of them are in such dense language. For someone with ADHD, trying to read through a very dense text can
Yes.
be a put off. So having something that is easily accessible is really useful. So thank you so much. And where can we find you in terms of your website and with people that want to connect with you? Where can we find you?
When in doubt, it's just Dr. Gilly Kahn. And the Kahn is
Okay.
Kahn. That's a common confusing point. But yeah, so I'm most active on Instagram and my handle is Dr. Gilly Kahn without a period. And then my website is drgillycahn.com.
Okay. Great. I'm sure we're going to have you back because there are many more topics that we would like you to talk to us about. And I'm sure our audience would learn a lot from that. Thank you so much. We're so pleased that you were able to join us for this session. Really pleased. And thank you for all that you shared. And we're looking forward to reading your book and having you back. So thank you.
Absolute pleasure. Again, thank you so much for inviting me.
Thank you. As we always say, early intervention leads to better outcome. And early intervention can only be achieved by early diagnosis. So thank you for listening into the series today. I know some of the things we've talked about today would probably have generated some questions or need to seek clarification. So I'm happy to take questions and I'll invite you to send your questions to eim@drtakon.com. Thank you for listening in.